supported us and made this course possible. So, oops. So the main sponsors are General Electric and General Richter, and Genus, but also Organon, Ferring, and Procare have participated. And I also want to welcome all the speakers and thank all of them. Dr. Stadmauer is a pioneer of IVF at Norfolk, where the first IVF baby in the US was born. She's an expert in fibroids, adenomyosis, endometriosis, and 3D ultrasound, editor of the best book of 3D ultrasound in reproduction, and she has made the effort to come here all the way from the IVF Center of Orlando in Florida. Thank you, Laurel. Belén Moliner from the Instituto Bernabeu in Alicante, a big fan of 3D, 4D ultrasound, always enthusiastic. She's the coordinator of the special interest group in imaging of the Spanish Fertility Society. Belén, is always a pleasure to work with you. And Peter Stinsma, application specialist from GE, who has participated as a speaker to our courses since 2010 in Rome. And it is always a pleasure to listen to his talks. So thank you, Peter, for being here. And all the members of FIVAP who perform and interpret 3D ultrasound every day, and who have actively participated in the organization of this course. And I welcome you also in their name. In order of appearance, Adela, who's a radiologist of the center, Gianpaul, Roberta Vicario from FIVAP Roma, Daniel Garcia, Juliana Guerrero, Jairo Hernandez, who's the chief embryologist by definition, but he's also one of the best ultrasonographers, I can say, in our center, and Danisar Vasquez, and Margarita Gallardo, and finally Manuela, who is not one of the speakers today, but she's actively participated in the preparation of all of our talks, and she's an excellent sonographer. So the practical part, when we go to the clinic, will be taught by Roland Mattern, Peter Stinsma from GE Austria, Luis Terran and Javier Gonzalez from GE Spain, and Giovanni Mazzoni and Lorenzo Gorgolini from Genus Accurate. And I wanted to also thank you, all of the staff of FIVAP, those that are not here also, who have all participated and helped us to prepare our courses, to work with our patients, to move the ultrasound machines from one room to the other, just to get the best image of a special case. So thank you to all of them. And a special thank you to Cristi Delgado and Eva Ramos, who are the main organizers of this course. Maria Perez for her support from GE Spain, and thank you to Javier, who has spent hours with us for the preparation of the practical part of the course. And finally, Fiona Schwab and Vilma Durante, who are really inspiring colleagues committed to innovation. So thank you to them. And let's start. I will present the program of these 2 days. The program is self-explanatory. We will start we kind of divided the talks into groups for subjects. We will start with a general introduction on 2D and 3D ultrasound, image quality, and ovarian reserve testing, and at the end we'll have a discussion. Then a coffee break, and I encourage all of you to come back in time for the next session. I also encourage you to ask questions and make the discussion useful. The second part will be on 3D evaluation of uterine and tubal anatomy, and again there will be a discussion at the end. Finally, there is a sono-EVC session speaking both about antral follicle count by the automatic sono-EVC method and about ovarian stimulation. So we'll have lunch here, and then we will move to the clinic. It's a 10 minutes walk. You all have maps in your bags, and we will start the hands-on program. Once you get to the clinic, you will find a list of names, so you will be divided into 3 groups of approximately 15 people, and you will all go through the same blocks. The first block is computers, and then simulators, and then Voluson and phantoms. So we will direct you to your place when you come to the clinic. Tomorrow, we will not start here. We will start with the hands-on in the clinic. And again, then we will move to this conference room for the theoretical part. We will have a very exciting session on adenomyosis, fibroid mapping, endometrial Doppler implantation, embryo transfer, and uterine peristalsis. Then the coffee break, and we will conclude the course speaking about pregnancy, that is necessary, and we'll have lunch, and then a small discussion if you need to ask more things, and then the exam. So please complete the evaluation form that will be given to you tomorrow, and that will help us improve future editions of the course. So I will start with my talk, and I will just give a quick overview of what we can do with 3D ultrasound and what we do in our everyday practice. At the end of this talk, you should be able to appreciate the advantages of 3D ultrasound in reproductive medicine as far as uterine morphology, ovarian reserve, and follicular monitoring. You should have a basic knowledge of automation technologies that can enhance efficiency. Become familiar with the concept of one visit infertility workup. Appreciate the advantages of 3D ultrasound in the era of telemedicine and COVID-19, although we hope that era has passed. And understand the role of simulation in training in reproductive medicine. I have no disclosures. And I want to present our clinic briefly. We have a medium-sized program performing about 600 cycles a year. And our pregnancy rates go from 60% in young women and egg donation patients to 10% in women over 43 and below 45, of course. And you can see here our pregnancy rate, our implantation rates have gone up in the last few years, despite the fact that we are making a point for transferring a single embryo, both in IVF and in egg donation, especially in egg donation. And we believe that the success of our program depends not only on the technological improvements in our IVF lab, but also on the way we diagnose our patients, we study our patients, and specifically how we use 3D ultrasound. So we take the patient through this process in the best possible way according to what we know. And so you see here how we have evolved from old clunky machines to agile machines that can be easily moved from one room to the other and then can help us work nicely with the patient. And this machine gives us better and better displayed images, as you can see here. I'll show you, these are just some examples of what you can do with our present equipment: multiplanar reconstruction, vocal, and sono AVC. And you'll hear a lot about all these things, both here and at the practical sessions. And here's another example of new technology, the uterine trace, a feature of the, for now, of just one of the machines, the Swift, but basically with the touch screen, you can immediately get the coronal plane, and then you can change the image, change the colors if you want, and trying to enhance the feature that you want to show. This improved technological ability has allowed us to accomplish what used to take multiple visits in a single visit. And with advances in technology, incorporating 3D ultrasound into a reproductive medicine unit has become easier and more cost-effective. And so I will show you during the next 10-15 minutes how we do it. So this is the normal uterus in MPR, multiplanar reconstruction with VCI, a rendered image of the same uterus, and a TUI, like tomographic ultrasound imaging. Again, a normal uterine with uterine trace. And what we do when we see a patient, we do an ultrasound, we acquire a volume of the uterus and the ovaries, and then we do the post-processing while the patient is getting dressed. And so this is more comfortable for the patient and more efficient. And during COVID, it helped us reduce the patient-doctor contact. So this is antral follicle count. And even when we do a sonohistogram, we acquire a volume and then we reconstruct the image. And as you can see here, we first look at the multiplanar reconstruction, then the TUI, then we apply this VCI, and we try again to find, this is silhouette, that's very nice, HD live. And we almost do a virtual hysteroscopy. That is, we see with the rendered image exactly what we will see in the hysteroscopy if there is a pathology, and go on to do a hysteroscopy. So here you can see all these polyps, and the same we saw at the hysteroscopy. Regarding uterine malformation, for example, a unicornuate uterus, it's very important to have the coronal plane. You can see here the multiplanar reconstruction and the TUI, and without 3D, probably it wouldn't have been so easy to make the diagnosis. This is a septum, incomplete. And here we have two different malformations. This is a septate uterus, so the fundus is unique. And here there is an indentation. It's a didelphys uterus because it has two cervixes. And this is very important. The classical teaching was to always perform laparoscopy when we did a hysteroscopy for a septum. And this is not necessary anymore. This is actually the last case where we did both laparoscopy and hysteroscopy for a septum. It just happened that the patient also had hydrosalpinges to remove. But now we don't need to be so invasive. Now we can just use the 3D, see that the fundus is intact, unique, and then we can start resecting. And at the end, we can also, as Dr. Guerrero will show in her talk, we can also follow the surgery with 3D ultrasound and make sure that the surgery is complete. Then we put a balloon in the uterus and give estrogen, and then we're done. So this is another feature, the OmniView, which is helpful to better delineate, for example, the certain parts, because you can follow the uterus and just go where you want to go. So here you can see the indentation and the two cervixes. And here, this is another malformation, septate uterus with double cervix and vaginal septum. And here you can see the fundus is 1, and we have 2 cervixes. And this is the TUI. And this is the OmniView. Again, it very nicely delimitates both the fundus and the cervix. As far as acquired uterine pathology, this is an intraneural fibroid with MPR, and the same with uterine trace. And so you can see all these images show you how ultrasound, 3D ultrasound, can be as effective as CT scan or MRI in showing us the details of the uterus in particular, we've seen now. So this is a TUI of the same, and this is a sonohistogram of a submucous fibroid here. You can see exactly how the fibroid appears, the TUI of the same, and with OmniView, we can really delimitate it. With the rendering, we can see it nicely. And the last thing we are starting to do is virtual hysteroscopy. Adela showed us how to do it. And we just go into the uterus with the camera, and exactly as if we were entering the cavity with a hysteroscope. And here you can see how the fibroid appears on the right corner, exactly as we will see in the hysteroscopy. This is a polyp, again, MPR with WCI and HD Live. You see submically. And this is another interesting case. It's a complicated case with fibroids, both intramural and submucous. And in this case, for example, the sonohysterogram with TUI on the sagittal place and with thick slices was the best instrument to show the pathology and plan our surgery. Let's go to assessment of fallopian tubes. You can see here, like this would be a 2D of the tube, and this is the rendered image. Look how nicely, how real it looks. And here the multiplanar. This is a virtual salpingoscopy, like another way of moving our image after we have acquired the volume and look at the inside of the tube. And here's the inversion mode, where you reconstruct exactly the tube. So this is a case of intraoperative sonohysterography with MPR and with the 4D. And this is almost like doing a laparoscopy. I mean, we could see exactly everything. Assessment of ovarian reserve. We use the Sono-ABC antral, and that was a normal reserve. This is a PCO, polycystic ovary, and this is a poor ovarian reserve case. We use Sono-ABC for ovarian stimulation, and this is how you acquire the volume of the ovary, and then immediately you can apply the Sono-ABC program, and the follicles will appear with a color code depending on their size. And here is our ovary, and you can exactly see how the follicles are. You have the two ovaries, and the report. This was very useful during the pandemic because we really reduced the time with the patient. We just entered the patient in the room with one operator, took the ovary, and then the patient would leave and we would analyze the images. So regarding SonoVC, besides the practical part of saving time, we believe it's more precise, more accurate to predict oocyte maturity. It allows decisions for trigger based on follicular volumes, and it has a relatively short learning curve. We published all this in Fertility and Sterility in 2010 and concluded our paper saying that SonoVC allows reliable evaluation of stimulated ovaries and may help us establish new criteria for timing HCG administration based on follicular volume estimation rather than follicular diameters. And 12 years later, that is at the beginning of this year, we published this other paper on volume-based follicular output rate for the prediction of the number of mature oocytes, sort of confirming and adding information to our previous findings, and finally showing that the trigger can be finally giving new criteria for trigger based on all our data and on these 12 years of experience. And trigger is now based on follicular volume according to this criteria. Two follicles, at least two follicles with a volume greater than 2 cc's, with 70% of the follicles having a volume greater than 0.7 cc's. So 0.7 is our cutoff volume for oocyte maturity. And in the same number of November of Fertility and Sterility, Dr. Eaton, at the end, commenting our paper, stated that clinicians may consider using forked volume to counsel patients on the day of trigger and set realistic expectations regarding the anticipated number of mature oocytes. So we're getting there. We're trying, we're almost reached the point where we can prove that follicular volume is better. And regarding egg retrieval, also SonoVC comes of help. We are, Adela, who is doing her thesis on this, she measures the follicles on the day of trigger by SonoVC, compares this volume for the volume with the volume aspirated at egg retrieval and with egg maturity. And this study is still ongoing. As far as embryo transfer, for years we've performed a 3D ultrasound after the transfer to determine the position of the embryo flush in the coronal plane. And we're trying to determine what is the best point to deposit our embryos. And also now we're starting to investigate 4D. You see here how nicely the catheter can be seen. This is really still at the beginning, and we need more investigation and more improvements on the part of ultrasound technology to really be able to apply this to clinical practice. Pregnancy confirmation, it's always nice for a patient to see the embryo after all this IVF journey, and we can easily, this is was done by Roberta Vicario, and it's a silhouette image showing nicely all the layers of the early pregnancy. And this is another case where we can see the vitelline artery. So really this ultrasound gives us a lot of possibilities. And here, okay, it's good for normal pregnancies, but it's even more important for the diagnosis of ectopic pregnancies. See here, this was a case where we identified the with 3D, we identified the ectopic pregnancy and see how the images really correspond to the images that we saw at laparoscopy. And also for this case, it would have been impossible to determine the exact position of the gestational sac with 2D ultrasound. So in summary, with advances in 3D ultrasound technology allows for the acquisition of a volume that can then be processed to obtain images in all planes as precise as CT scan or MRI, and this is of paramount importance to make a correct diagnosis and plan treatment in preparation for assisted reproduction. 3D sonohistograms and automation tools such as SonoVC antral and follicle enable a more precise diagnosis, treatment, and monitoring. The availability of 3D ultrasound in our clinic allowed us to adapt our practice during the COVID pandemic in a new, safer way, and it's now the standard of care in our practice. The topics pointed out in this introduction will be developed in detail along the course by my collaborators and other speakers. So I'll briefly touch on simulation. This is a flight simulator, and simulation has become an integral part of physician education. Hundreds of articles confirm that simulation-based education improves learners' skills and behaviors and is associated with improved patient outcomes. Simulators for egg retrievals and embryo transfer have been shown to be useful for training of REI fellows. And in this course, you'll have the opportunity to use simulators of egg retrieval, embryo transfer, and sonohysterography during the practical hands-on part. And finally, I want to thank all of our patients and our babies that keep coming to the world. So thank you very much, and we can move on to the next talk. That's going to be Peter Stinsman.